morning, everyone. This is Carla with NeedyMeds. We're going to get today's presentation started in just under a couple of minutes. In the meantime, I'm happy to see that a number of people have already joined us. If you wouldn't mind, and to our attendees, to go ahead and send me a message in the question section of your GoToWebinar control panel to let me know that you can hear me clearly and that you can see my screen, which is the first slide of our PowerPoint presentation. And it looks like our guest for today has also joined us. So Lucilia, if you're there, I'd appreciate if you would just give us a shout out to make sure we can hear you.
I'm here.
Well. Fantastic.
I'm here. Good morning, everybody.
Good morning. So thanks, everybody, for your patience, and we're going to get the webinar started in just about a minute. In the meantime, you will hear silence. Thanks so much.
Are you able to see my slide?
Not yet. We'll be able to see that as soon as I change the presenter to you. Right now, you should be able to see my first slide, which is the my screen, which is the first slide of a PowerPoint presentation.
Okay.
And thanks, everybody, all of our attendees, for your patience. And we're going to get started in just a few seconds. Thank you. So good morning, and thank you, everyone, for joining the NeedyMeds special topic webinar, The Costs and Consequences of Healthcare Errors, Fraud, and Abuse. My name is Carla. I'm the Director of Education at NeedyMeds. And before we get started, I want to go over a few tips. If you have any questions, you can feel free to type them into the questions section of your GoToWebinar control panel, but just know that we will reserve answering all questions until the end. If for some reason we don't have the time to answer your questions, we will follow up with you personally via email in about a day after the webinar. But of course, we will also provide you contact information for our organizations. Also, this webinar is being recorded and will be available for viewing on the NeedyMeds YouTube page. And we try and make the conversion from our webinar to a video within a couple of days, so it should be on a NeedyMeds YouTube channel at the end of the week or the beginning of next week at the latest. So with that, let's get started. For those of you that are not familiar with NeedyMeds, there's a snapshot of our homepage, and I always put that up because really our website is the face of our organization. Anyway, NeedyMeds is a national nonprofit, and that slide you're looking at on your screen is our mission statement, stating that we are dedicated to educating and empowering those seeking affordable health care. And we really define education in two ways. One, by educating people about NeedyMeds and the resources we offer. And two, by letting them know about other invaluable resources and timely healthcare topics, which is why we are so pleased to have our expert guest here with us today. It is my pleasure to introduce Lucilia Prates-Ramos. She is the statewide director with the Massachusetts Senior Medicare Patrol, SMP, program. Lucilia has been the statewide director of the Massachusetts Senior Patrol program since 2002. She has served on multiple boards and advisory councils for foundations and a number of nonprofit organizations. In 2007, Lucilia was appointed to the Massachusetts Department of Public Health Council, and she was reappointed recently for another 6-year term. Today, Lucilia is going to demonstrate the cost and consequences related to healthcare errors, fraud, and abuse. Her presentation will highlight the actual money wasted and how it could be used for other essential services and programs to serve our aging communities. So without further ado, I'm going to go ahead and pass the mic and the screen to Lucilia. Lucilia, you should be able to go ahead and grab the screen from me. Everybody, thanks again for your patience and enjoys today's presentation. Lucilia, that looks perfect. Thanks, everybody.
Great. Thank you. Good morning, everybody. I have a little echo on my end. I hope that you don't have the same thing going on.
Me,
But anyways,
to me
I'm going to present to you.
Yeah, to me you sound pretty clear. Yep, thanks.
Great, thank you. So I'm going to be presenting to you, as Carla said, on the cost and consequences of healthcare errors, fraud, and abuse. Healthcare errors, fraud, and abuse not only cost American taxpayers a significant amount of dollars, in the billions, if you will, but they can cost you your life or the life of a loved one. So today's presentation, I'm going to tell you what the SMP program is, the Senior Medicare Patrol, the differences between fraud, errors, and abuse, how we see them from where I sit, and how you can help detect them and protect against them and report them. Because if we protect, detect, and report, I think we're going to make a dent in the money that is being wasted. I'm also going to introduce our personal health care journal and encourage all of you to use one and encourage those that you love, friends and family, to also use them. And I'll tell you about the new Medicare card that's going to be coming out in April of 2018 and give you some additional resources. So the Senior Medicare Patrol program is a federal program. There are 54 programs. We're funded by the Administration for Community Living. There's one in each state. There's one in Guam, Puerto Rico, U.S. Virgin Islands, and Washington, D.C. The program came about around the time that welfare reform was signed into law in 96, and the SMP program was created in 1997, essentially to protect, detect, and report healthcare errors, fraud, and abuse, and to engage consumers, to show them how to read their Medicare summary notices and be more attentive to their bills. So the SMP program mission, the overall national mission, is essentially to empower and assist Medicare beneficiaries, their family members, caregivers, and others that help them in navigating their healthcare system to prevent, detect, and report healthcare errors, fraud, and abuse. And we do this through outreach, counseling, and education across the country. We're a volunteer-run program, so if any of you are on the phone and you'd like to volunteer, don't hesitate to get in touch with us after this. I had to make that pitch, Carla. The Massachusetts Senior Medicare Patrol program.
Absolutely.
The Massachusetts Senior Medicare Patrol program essentially has the same mission. We have the same mission, but our vision is a little bit more left-handed, and that is that we reach, educate, and we really try to activate Medicare and Medicaid beneficiaries to take charge and to engage their family members and their caregivers. And also, we encourage professionals to be more, to work more in partnership with consumers and to understand the importance of consumers being better engaged in their health care. You know, today we all talk about consumer-centric care and patient engagement, and that means something very different to each and every one of us. And so I think we need to sort of sit back and understand what that means and then try to have the same language so that we're all on the same page. And oftentimes that's not the case. How do we accomplish our work? The Massachusetts Senior Medicare Patrol program accomplishes its work through fostering partnerships with mainstream organizations and community-based organizations so that we can reach the populations that are most vulnerable, who have limited English proficiency, who may be homeless. We don't have any credibility with those organizations, so it's imperative that we foster those partnerships. So we work very collaboratively to promote a better understanding of how people can be better engaged in order to identify, protect against healthcare errors, fraud, and abuse, and its overall impact and how it impacts, you know, the individual. It impacts us as taxpayers, the community at large, the medical community. Everyone's impacted by this. We do a lot of cross-referencing of consumers. For example, we constantly refer individuals to the SHINE program, which is a SHIP program in most states. In Massachusetts, we call it SHINE. It's the state health and insurance program. And the SHINE program in Massachusetts, we actually have established a cross-referral mechanism where if a SHINE counselor is seeing somebody and they detect that there's something possibly going wrong with their case, with their questions, and that their bill might actually be a case for the SMP program, they will automatically fill out a form and send it to us, and we will follow up. And then we'll have that interaction with between the SHINE counselor and the SMP counselor to address those issues. I'll give you a good example. We recently received a case from a SHINE counselor, a SHIP counselor, SHINE counselor, about an individual who had paid for physical therapy, and the allegation was that the insurance company also had paid. And so we went and tried to research that and sort that out and really make sure that the person who was the entity that was responsible for payment paid, and not the Medicare program or the beneficiary. So that can take us in many different directions, and it's hard to navigate, especially if you're older and you're sick or you're in pain. So we do a lot of that work with individuals. What is fraud? Well, fraud is when someone intentionally, knowingly, and willfully lies in order to be reimbursed for something, for a service or a product that was not provided. So, and I think we all know that. So it's important also to know that there's billions of our tax dollars lost each year to fraud. Over $60 billion is lost to fraud annually. That's representative of 10% of the Medicare budget. That's a big number. And we need to save Medicare for future generations. We need to do everything we can to safeguard it. And if you put waste, fraud, and abuses and overusage and whatever else you can think of that's going on in the delivery of care inappropriately, that number can balloon to over $250 billion, according to the Center for Program Integrity at the Centers for Medicare and Medicaid Services. So that money could be put towards a lot of good services for people who need them. At one point it was said that if we were to cut out waste, fraud, and abuse in the healthcare delivery system, that we could pay for health reform. So important to keep in mind is that fraud is an intentional deception or misrepresentation that's going on. And I think we all have a role in trying to pinpoint it and identify it, and when we see it, to say something about it, because ultimately it's costing all of us. So here's I'm going to show you 5 Medicare fraud schemes that have come to our attention, and that our volunteer group who works on an ongoing basis and revamping our presentations have identified as something that they use as an example to show individuals to really drive this home. And this is based on stories that have been in the paper. So the top Medicare fraud schemes are services that are not rendered, drug diversion, upcoding and unbundling of tests, and upcoding of services received, and then the false front provider offices. At a strip mall, for example, you might see a certain durable medical equipment where really nobody ever steps foot in the door. It's just there so that it becomes utilized, and then they can bill Medicare for items that, you might have some people cold calling. I think we've all have experienced, and some of us possibly even victimized, by a phone call from somebody offering braces, asking us if we have pain, And, you know, somebody signs up for braces, and next thing you know, they're getting a brace for their back, a brace for their leg, a brace for their arm. We have consumers who have been victims of such scams, and what happens is that they end up getting braces for parts of their body that they don't know how to use, how to put on, and what the functionality of it is. So it's important to be aware of that. So here are some examples of fraud, errors, fraud, and abuse that we see. Medications, incorrect amounts of medications, duplicate, unnecessary medications being prescribed. This is seen in long-term care facilities sometimes. So we just need to be very watchful. Lab tests, billing for tests not performed or performed unnecessarily. X-rays, the wrong body part being X-rayed, unnecessary X-rays being done. I think we all have to be more aware and ask more questions about, you know, what is being prescribed to us. You know, why do I need that? And to ask that question of our providers. So, not your bill, wrong person being billed. We see that very often come before us where, you know, the wrong Medicare number was used. And sometimes it's as simple as a transpositional error, but nonetheless, that person's number has been compromised. And if someone is not being vigilant about looking at their Medicare summary notices and noticing, gee, you know, this doctor billed for something. I never saw this doctor. I was never at this institution. What's going on? And then to call someone about it and trying to better understand what happened, because I'll give you a good example. If somebody had a wheelchair billed to their Medicare account, well, and they actually, within the next 5 years, possibly need a wheelchair for themselves, they're not going to be able to get one. So we need to be a little bit more engaged and encourage those we know and love to do the same. Unnecessary surgery. I actually gave a talk last night somewhere, and someone told me that they had been convinced that they needed surgery, and come to find out they didn't need surgery at all. And the story really drives it home. It gave a lot of credence and credibility to what I was talking about when that woman piped up out of the audience and said, that happened to me. Elaborate surgery and overusage. We see some of this happening. So just people need to be very watchful and very engaged when they go and see their providers. And to keep a journal. We'll talk a little bit more about the journal as we move forward. Home health is an area we also see some fraudulent action take place across the country. Billing for home care services when Medicare criteria is not actually met. So, for example, the person is not homebound or doesn't meet the homebound criteria, or they don't need skilled services. Billing for skilled services when they were not provided or provided unnecessarily. Billing for more visits or services than were actually provided. And then poor quality. Quality is a real issue. And if people are questioning quality, they should call someone and inquire about that. We should all be getting quality health care. And unless we speak up about it, it won't be fixed. So here's some major fraud cases of 2016 in Houston-based home care. False claims to Medicare equal $13 million. A hospice care scheme equaling $7.5 million. You know, and that's a pretty sad situation where a patient, this entity was paying patient recruiters and physician was certifying the patients were dying within the next 6 months when they really were not. And the reason for this is because billing is done differently. So major fraud cases for 2016, I think you can see the screen. I'm not going to bore you with the reading of it, but 3 Miami home health agencies defrauded Medicare for $40 million. In Los Angeles area, rehab and physical therapy billed Medicare $15 million. And so we're talking millions and billions. Miami area skilled nursing and assistive living facility, $1 billion. And the Tenet healthcare bribes and kickbacks paid to prenatal clinic owners in exchange for referrals to their labor and delivery practices, agreed to pay back the government $513 million. So this really runs the gamut of all consumers. It's not just Medicare. It's Medicare, Medicaid, and it happens also with, your private insurance companies. In fact, if you're a Medicare beneficiary and Medicare pays out, the 20% that the Medigap plan, the supplemental plan, they automatically will also pay because Medicare has paid. So we're talking a lot of people being defrauded, a lot of money out there that is being wasted, and that we all need to be a little bit more vigilant about, so that the services that we need, medications, look at the cost of our medications. I think that speaks volumes. What are errors and abuse? Errors and abuse are unintentional. They're incidents and practices or procedures that are not consistent with sound medical, fiscal, or business practices. And they may result, and they often result, in payment for services that fail to meet professionally recognized standards of care and or medically unnecessary. And we're human, we make errors, we unintentionally make mistakes as we're inputting or coding things. And I'm going to share a personal example with you. In 2008, I took a fall and got pretty banged up. I fell down my basement stairs. I had the wrong shoes on, and I was doing all the right things in a rush. So I went down the basement stairs, and I fell. I hit the cement and came back up on impulse. I don't remember coming up. I actually have suffered 2.5 hours of amnesia, and I don't think I'll ever get it back. The doctor tells me I won't. So I went to the hospital. I got excellent care at the hospital. What happened was I convinced the doctor I broke my arm. I suffered a concussion. And so they did all the right things and made sure I didn't have a cerebral bleed. And my arm, they wanted to put in a cast, and I was going to travel that week. And I pleaded, I bargained, I bartered, I did it all. And I left there with a sling. And so I came home with some painkillers, and that they probably wouldn't prescribe today, and my sling. Around noon, and so I was there all night. I left at 5, 6 in the morning. Around noon, I got a phone call from the emergency room asking me to go back in because the orthopedist who was in the emergency room during the day wanted to see me. So I went back in. They were going to put my arm in a cast. So I went back in, and I got signed into the emergency room, and I said, I just left here. And you guys called me back in. I don't want to sign this. Well, I needed to sign. Okay, so I signed it. But I wrote on the back of the form, I just left here. I don't want to be billed for this. Please don't bill me. I will not pay. I wrote everything I could think of. And I didn't want to have that emergency room copay of $50, and I didn't think it was fair. and I had needed to walk the walk and not just talk the talk. And so I went to see the doctor, and I walked in, and he said, well, how are you feeling? And I told him how I was feeling, and he said, well, there are two schools of thought. Literally, I was in there 2 minutes. He said there were two schools of thought for the fracture you have. You can either stay with the sling, or you can, we can put you in a cast. I said, well, I think the decision was made earlier this morning. I don't want this cast. And he sent me on my merry way. I wasn't very happy because I felt it was a waste of time, a waste of my neighbor's time who drove me to the hospital. But I left gratefully that I didn't end up with a cast. So fast forward, a few weeks later, I get my bill in the mail for the 7th of March, which was when I took the initial fall. And I had a $50 copay. And I promptly sent them a check for $50. And then a few weeks later, I get another bill in the mail, and the bill is for the $50 for the 8th when I walked in for that second visit at their request. And as I looked closer at the bill, there was a $20 charge that I needed to pay for the sling because they don't pay for elastic slings, according to the person I spoke with at the hospital. I said, well, there's nothing elastic about my sling. It was white material, no elastic. I still have the sling. And so I said, I'm going to call the insurance company. So I called the insurance company, and I speak to someone at the insurance company who then said to me, oh, and I looked closer at the bill, and I saw a $270 charge that had been paid by the insurance for prepping my arm for a cast. And I thought, this never happened. And I had not looked at the bill, I have to confess, as I should have when I initially got it. So when I was talking to the insurance company about the $20 sling, I said, and by the way, $270 were paid for prepping my arm. My arm was never prepped. I opted for a sling. I never got a cast. They didn't do anything to my arm. And so the woman said to me, well, we can't retract payment. We've already paid. And I felt like at that point in time, I really felt like I just needed to walk away, throw everything I had on my desk out the window and say, what am I doing? So I thought about it a little bit more calmly, and I said, I would like to speak to your manager. So I had a conversation with the manager, and she, assured me that, of course, we can retract payment, as I thought they could. And I then had a conference call with somebody at the hospital where I was treated in their billing department and pointed out all of these issues to them, and then left them to their own devices because now we have the insurance company on one end of the phone, and I'm having a three-way conversation with the hospital, and it's like, you guys have paid them. They shouldn't have been paid, and I'm not paying you the $50. And so they sent me a nice letter telling me that they were going to waive it. And I said, no, you're not waiving it. You shouldn't have been charging it. But I left it at that. But these things can happen, and it only took me a week to sort through that mess, okay? And I do this for a living, and I've been doing it since 2002. It's not easy. Had I been an elder, had I been one of my parents, they wouldn't have been able to do it. Number one, they have limited English speaking proficiency, and they would have given up and probably paid the bill. So with all of that detailed, boring story, I just want to point out to you that nobody's immune to this, and that we should all be very vigilant, and we should all be asking many questions. And I'm going to take you on to the next slide. So the next slide is on durable medical equipment. We see a lot of issues with durable medical equipment. And, in fact, in a previous example I mentioned was a wheelchair, how you can, if your number gets compromised and a wheelchair is given to someone where your number has been utilized, that you could, or the Medicare beneficiary could, be denied a wheelchair down the road. We also see some concerns with oxygen. We've actually recently done an analysis of all the cases that we have, and durable medical equipment and oxygen are among the top concerns. Excuse me. Ambulance versus chair car. We get a lot of complaints about this. What's important to remember is that ambulances, or the cost of ambulances, Medicare will cover emergency and non-emergency ambulance services if transportation is medically necessary, meaning that an ambulance is the only safe way to transport a patient. And the reason for that transport or that trip is to receive a service, okay, or a return from that service that the patient needs and Medicare will cover. That's important. So we get a lot of people who have been denied payment of Medicare because of how the billing is coded upon arrival in the emergency room, and then the person gets sent the bill from the ambulance company. And the ambulance cost for an individual is a lot higher, okay, than if Medicare or an insurance company is paying for it. And a private pay ambulance transport can cost, a 5-mile ride, if that even, can be $1,500, whereas for a private pay. Whereas if Medicare is paying that bill, really, these are not accurate numbers, but they're on the mark, could be probably $300 or $350. So there's a great difference. We've recently had just resolved a case of a gentleman that we ended up appealing. His ambulance not being paid for. This man had a cardiac event. He ended up in the emergency room. He got admitted to the hospital. And, I think the bill was out there for over a year. When he finally came to us, we were able to resolve it by filing an appeal with Medicare on his behalf. So, again, one is transported to and from certain locations, and the supplier meets Medicare ambulance requirements. That's imperative. And a chair car is never covered by Medicare. So that's an important, it's important to realize. ABCs of Medicare, I think people probably are familiar with this, but I'm just going to quickly review it for you. So it's a puzzle, and it's a messy puzzle. So we have Medicare A, Medicare B, Medicare D that really work together. This is original Medicare. And Medicare C, which people don't often hear about, is your Medicare Advantage plans. And those are the plans that are more HMO-like. They are HMOs, where you have to stay in the network. So for people who, for example, travel and go to Florida on their snowbirds or go elsewhere, California, Arizona, you might really want to see a ship counselor because I wouldn't recommend that because you need your insurance to work for you wherever you are. So Medicare basics. Medicare A pays for inpatient care, skilled nursing facility, hospice care, health care for homebound beneficiaries. And B pays for doctors, outpatient care, home health care, physical therapy and occupational therapy, and durable medical equipment. Medicare C, again, is your Medicare Advantage. This is a little bit more spelled out for you, where it's HMOs and PPOs. And then D pays for prescription for drugs. And then if you have A, B, and D, you absolutely need a Medigap, a supplement to A and B. Medigap will pick up the 20% because Medicare only pays 80%. It was never intended to be a program that would pay 100% of one's care. If there's anyone on the phone who's a Medicare beneficiary or is a caregiver to a Medicare beneficiary, Medicare and new books have been sent out. I think they were sent out in October. Medicare Renew 2018 is out, and people should really read it. When I do presentations with older consumers, I say to them, you keep this book by your bedside, and when you cannot sleep, you start reading it. You might get through one page, and I promise you, you'll go to sleep, and you won't need any prescription for your insomnia. And this is how we can help. We can all be out there trying to detect and asking questions and protecting, by really being more vigilant, we are protecting everyone around us. We're protecting Medicare for future generations. And we need to report it, because if it doesn't get reported, if it doesn't get written down, written up, then it really never happened and it doesn't get really resolved. So, and I'll give you an example of that. One can call their provider and say, you know what, I've been misbilled. And I think that most providers will say, and they have every intention of doing this, we will take care of that. We will fix the bill, make sure you don't get one, and we will, inform Medicare, and we will return payment to Medicare. And they may do that, but we're looking for patterns that if hospital A, this happens with some frequency, and there's a pattern of something being billed that shouldn't have been billed to the consumer, then these patterns are identified, and the quality improvement organization that does capacity building with doctors' offices, private practices, and hospitals will look at this information and say, gee, we need to do a little bit of capacity building in this part of the country. So I'll give you an example. The quality improvement organization that we often refer cases to, we're having a retreat next week, and I wanted him to come and speak, and he said, gee, Lucilia, I'd love to, but I can't because I'm going to be out in California. He's our liaison with the Quality Improvement Organization. He said, I have to be out in California. I need to be doing some capacity building on the West Coast. So, again, those are patterns that have been identified, trends, and they're addressing them. Because what we want is we want our healthcare systems to work best for all of us, to work at their max. So we encourage people to protect their Medicare card, their Mass Health, their Social Security card, like they do their credit cards, because they are important. We don't want people's Medicare numbers to be compromised. Carry the card only when needed. That is when you're going to the doctors, when you're visiting hospitals or clinics, or going to the pharmacy to pick up your medication. And typically, I say to people when I'm doing presentations, beginning of the year is really when you're going to need them, because we tend to go to the same pharmacy, we tend to go to the same doctors or the same hospitals, the same clinics, and they have that information on file. People are maybe during open enrollment are changing their insurance providers, and so at that point in time, I think a lot of practices and a lot of hospitals and clinics really want to see the documentation. But, I'm going to say February, March, and once somebody has been to the doctors after the first of the calendar year, I think it's wise to say you might not even need them. But definitely be very watchful of these cards. We encourage people to be as engaged as possible, to keep a personal health care journal. We have journals. We can send them out. If you're in Massachusetts and you want to call us, we'll mail you one. If you're outside of Massachusetts, you want to call your local Senior Medicare Patrol program. Later in the presentation, there will be information about the Senior Medicare Patrol Program Resource Center, and you can log on to the Resource Center and find out the contact information for your local SMP, for your state's SMP program. We encourage people to document all of their healthcare interactions, all of their visits to the doctors, the diagnostic testing, any procedures, all care plans, medications. Do you have a care plan? do we mean the same thing about, do I mean, when I say care plan, maybe it's not what you're thinking. I mean, that's another term that I think we all need to be on the same page about. Documenting all of your medications, any changes in your medications, having it handy if somebody asks you for your medication list. Now, I think what we're seeing is a lot of doctors' offices and clinics and hospitals will, in fact, give you your medication list when you walk in if you are one of their consumers. Or when you're about to see the doctor, can you confirm that these are the meds that you're on or that your mother is on? But if you have that all written up on in the healthcare journal, it's all the easier for you to be able to verify. So, and also to prepare for your doctor's visits. You only have 10 minutes with that doctor or that provider to write down those questions for the healthcare provider, and then write down the answers, and to make sure you understand the answers, because sometimes they just speak a different language. And we're nervous when we go into the doctor sometimes, and we're worried about something. Oh, I was supposed to lose X pounds, and I didn't do that. He's going to give me crap for that. Well, let's, talk to them, develop a partnership. But write down those questions, and I bet you 9 times out of 10, when you are prepared for that doctor's visit and you're taking notes and you're being active in that visit, the rapport with that provider is very different. So an important thing that I want all of you to know is that we now have a CARE Act, and CARE stands for Care Advice, Record, and Enable, and God forbid we didn't have an acronym, right? We all speak in alphabet soup these days. But this is an important law, and it features 3 important provisions related to family caregivers' role when a loved one is hospitalized. So the hospitalized patient is provided with an opportunity at that point in time to designate or identify someone to be their family caregiver. The family caregiver is notified if and when the patient is to be discharged to another facility or back home, and the facility must also provide an explanation and in-person instructions, of the medical tasks that the family caregiver is expected to perform, such as medication management, the injections, if there are any injections, a wound, medication administration, if they have a PICC line and they need to get their medication administered. How do you transfer an individual if that's something that needs to be learned? And this is very important, because when the family caregiver goes home and is left alone with the patient and needs to perform these tasks, they really need to understand how they are performed. So I'll leave it at that. Think about this. If you are a caregiver, this exists, this law, and it should be able to facilitate life for all of you. Another important thing for people to know is about the MOON memo. And here's another acronym for you, the Medicare Outpatient Observation Notice. I don't know how many of you have come across or heard about outpatient admissions, otherwise known as observation status. So this Notice Act was signed into law in 2015. It requires that all hospitals provide written and oral notification to Medicare beneficiaries and as of March 8th, 2017. This was put into place. So the MOON memo is a standardized notice that informs consumers that they are under observation status, they're admitted as an outpatient, and they are receiving services as an outpatient, and they are not an inpatient admission. Observation status can have financial consequences to the beneficiary. So, for example, if somebody falls and breaks their hip, They go into the emergency room. They go into surgery. They have, their hip repaired. They're kept under observation, and they're sent to rehab before they meet a 72-hour requirement. It's called the 72-hour rule of being a full-fledged inpatient admission at the hospital, and they're sent for rehabilitation services as a skilled nursing facility. That skilled nursing facility is going to be not covered by Medicare, and the person will have to privately pay. That is approximately $500 a day. At the end of the month, we're looking at $15,000. We have cases that have come to our attention just like this, and there's very little, nothing that we really can do. And this is unfortunate, but it is what it is. I am not, but one of our counselors is working on a case of an elderly woman who went to the hospital. She took a fall. She broke some ribs. She was kept under observation, and she wasn't even in there, I don't think, 24 hours. But let's say she was there 24 hours. And then she was sent to a rehab. And they're just, their life savings is just dwindling away. She's been in a rehab for months now. And we're trying to hook her husband up as a community spouse with legal services so that he can get what's entitled to him as a community spouse, because he needs to think about taking care of himself. He's also ended up in the hospital several times because of all of the stress around this. And so this can happen to anybody again. It's not just around broken bones. One could go into the hospital, with chest pain or what have you, and they will be kept under observation and not admitted. There are consequences. If you are under observation, or the Medicare Part A is not paying for meds, and your medications are not paying, you can't take your medications that you have at home. This can play out in very different ways. One could end up paying, $7 or more for a Tylenol or an aspirin. So we need to be, again, very vigilant, ask a whole lot of questions of the providers. So recently, my mother was admitted to the hospital, and one of the things I wanted to know was, is she a full-fledged inpatient admission, or is she here under observation? Because, when you get admitted, we're keeping you because we want to observe you. Well, you want to observe me? This is observation, or is this inpatient? Am I outpatient? What is going on? I think we need to ask those questions. And we'll be looking now for the Medicare Outpatient Observation Notice, the so-called MOON memo. So here's our lovely journal, and some people don't like our journal, in particular men, because it doesn't fit into their coat pocket. So, and I'm sure other people don't like it because it's a color or what have you. But you don't like our journal, you don't have to like it, but you have a journal. Go buy a purple notebook, a pink, or multicolored with pockets. But keep a journal of the dealings with the healthcare system, and take the journal to every appointment and record all the doctor's visits, the diagnostic testing. I am repeating myself, procedures and medications. Prepare the questions for that medical appointment, really important. Keep Medicare statements and bills, explanation of benefits, for at least 2 years. Compare all of these documents and these statements against the medical journal, the personal health care journal. Carry the journals when traveling. You never know what could happen. You might have left your medications at home. You have them handy. If you need to go to a drugstore and say, geez, I'm on this diabetic medication and I'm on a trip, I left it at home, Can you help me out? Maybe call the doctor, what have you. But you've got that information right there and very handy. Also, we encourage people to log on to mymedicare.gov. I'm going to also share with you that Medicare does not pay for 9 hospital-acquired conditions. Okay, they pay at a very different level, if they pay at all. For example, if somebody is a victim of a foreign body being left inside them, an air embolism, a transfusion of the wrong blood, severe pressure ulcers, follow trauma that takes place in the hospital where someone sustains a fracture, joint dislocation, head injury, crush injury, burn, electrical shock, a hospital-acquired infection, and the list goes on. So Medicare does not reimburse at the same rate, or if they reimburse at all, nor is the consumer supposed to get a bill. So people, again, need to be vigilant, need to use their journals, need to write down what their diagnosis they're walking in with and what diagnosis or diagnoses they're walking out with. And for those of you who have aging parents or relatives, they need our advocacy. They are in tremendous need of our advocacy. I'll leave it at that. The Medicare Summary Notice is a document that sometimes people have difficulty understanding and reading. So I say to people when I do presentations, I say, make sure it belongs to you, that in fact it is your name, it is your address, and that it is your Medicare number, that those last digits are yours and then they're not somebody else's. Look at the dates of service. Make sure you were at that particular place. That, for example, what's up on your screen, that on June 18th of 2011, that I did see Jane Doe, doctor, and that I did go to this physical therapy on Main Street, at any town, any state. And look at the numbers. And do they make sense to you? And if they don't, call somebody about it, because no question is a silly question, and people really need to understand what is happening to them, what they're getting, what they're not getting, what was provided, what wasn't provided. June 28th, okay, Craig Sackison, doctor, okay, phone number, all of it's there for us. This person had an eye and medical examination for diagnosis and treatment, and the amount provided charge was $143, and Medicare approved amount was $107.97. This person has a condition because Medicare doesn't really pay for eye care, but he's got some issues with his cornea. So amount paid was 80% of the 107, and then the person may be billed at $21.59, or that gets sent to the Medigap plan. So if one has a Medigap, that's who's going to pay for that. Okay, everyone has the right to appeal, and I say to people, appeal, appeal, appeal. When in question, appeal. Medicare non-payment appeals, okay? The individual must sign the back of their Medicare beneficiary and submit it to Medicare within 180 days. The other types of appeals are hospital discharge appeals, skilled nursing facility discharge appeals, and quality of care complaints. And those get sent to Levanta. And I'm going to send Carla a gaining access list, and you can post this up on your site, Carla, because it'll give people all of these numbers.
That'll be really helpful. Thank you so much.
Yeah. So Levanta is a great place to call if somebody is in the hospital, Medicare beneficiary. This is for Medicare, Medicaid beneficiaries, okay? Medicare, you're in the hospital, your parent is being discharged, you feel like there's no way my mother feels well enough to be discharged. you call Levanta and appeal that discharge. It may get granted, it may not, but appeal it. Skilled nursing facility, discharge, appeal again if you feel that person is not ready to be discharged. And I will share with you that my mother, when she was hospitalized, she ended up in a skilled nursing facility for rehabilitation. My mom has dementia, and so when the PT person would come to her, she'd say, no, I'm not walking now. She's on her own timeline. And so I would say to them, you need to redirect. You need to go and see her, multiple times throughout the day. She needs to be worked with, but, she's got dementia. You've got to account for that. And I would show up and try to be there, and sometimes that worked and sometimes that was worse. And so my mom was in a semi-private room. Discharge was nowhere in the plan. We hadn't been informed. We had had family meetings. And then she got moved into a private room, and I thought to myself, she's going to be discharged any day because she was going to be paying higher dollar, and she was a self-payer, I think, in a very malicious way, I think. And so I then I said to my siblings, you know what, she's going to be discharged. I can feel it. And sure enough, we got a call that she was being discharged, and I said, well, I'm appealing the discharge because I don't think she was ready. And I really, and the truth is she wasn't, because I said I called Levanta, and I said, she needs more therapy. And I stated my reasons, and they approved her my appeal. They ruled in her favor. She stayed for an additional 2 weeks. She was able to get her walking a little bit more stable, and she was then able to go into an assisted living as opposed to a nursing home, which was what was being recommended before she had her more up-to-snuff therapy that I felt she needed. So, again, appeal, advocate. Quality of care concerns, complaints. If you feel somebody is not getting good quality of care, those need to be reported to Levanta, those complaints, and they will look into them. And sometimes they rule in favor of the beneficiary, and sometimes they don't. We just had a case that we felt really they should have ruled for the beneficiary on the complaint, and they didn't. And they did do a review. They reviewed it twice, 2 independent reviewers. On the other hand, we've had cases that they have ruled against the provider, and that the beneficiary shouldn't have been treated in that way, that they got poor treatment. We recently resolved a case, and last year we had another one. So these come to us, and we try to help people navigate that system as well. Sometimes we'll do a 3-way conversation, conference call with Levanta, the consumer, and us probing, because we have done a lot of researching and talking to the individual, and sometimes all of those tidbits of information don't come out during the dialogue with the Levanta rep, and we can add to that information and discovery process. So report, and we want people to take these steps. Definitely call their provider, because our program is all about empowerment, but also call the Senior Medicare Patrol program, because as I mentioned before, sometimes the provider will, is more than willing to take care of the issue, and may not, but then nobody really knows about it. So no one is picking up on the trends, and the QIO, the Quality Improvement Organization, really doesn't know that they need to be building capacity with a particular entity. Or they could say, you know what, I'm going to send the money back to Medicare and really never do it. because it's one more thing for them to do, and the money's already in-house. But if we put it into our system and report it to the contractor will follow that and make sure that that money, in fact, was returned. And to call Medicare if you have any questions, Medicare will probably send you our way. Also for Medicaid, we send those, we encourage people to call the Office of the Attorney General, and we also work very closely with them. And to call the Insurance and Financial Services Hotline, and this is their number. And this will be available to you after the webinar. Also, to call the Elder Consumer Hotline. These are the two numbers that are utilized, the Attorney General's. Medicare cards. As we all know, our Medicare number is either our Social Security number or the Social Security number of our spouse or our parent, for those of us who became Medicare eligible and never had and got it through our parents. So Medicare cards, as of April 2018, Medicare will replace current Medicare cards with a new Medicare beneficiary identifier number. It will not be a Medicare number, so you can compare old, current card and the new card that's going to be coming out. All the cards, this will be done incrementally, and I'm not sure what the order necessarily is, but it could be that I get my card or my mother gets her card in April of 2018, and my father won't get his until, March of 2019. It's going to be dependent on their number and their sequence of mailing the cards out to people. The important thing to know and to advise people about is that no more will the Social Security numbers be on people's Medicare cards, and the cards will be sent out free of charge. And Medicare will not call to confirm Social Security numbers or to confirm receipt of cards. Now, I know this for a fact because it's already happening, that people are calling in different parts of the country. People are getting calls saying, we're about to send out Medicare cards, and we want to confirm numbers with you. We want to confirm your date of birth. So already I think that there's very clever scam artists out there, scammers, who are already on top of this. So I think we need to be very vigilant to say to people, never, ever, ever give out any information over the phone, and not to fall for these stories that they call with. And they're very compelling sometimes and very believable. So we can all fall victim to them. So just to encourage people not to give out any information, not to believe that they are costing anything, because they're not. They're not going to be able to expedite this in any way if they pay a certain amount. I think that we're in for a very busy spring season addressing some of these issues. So here's some important reminders for you. Repetitive, but I think that we can never say these enough. Do not carry Medicare cards. Encourage those you love not to carry them except when going to medical appointments or pharmacy. Do not provide your Medicare number, or encourage people not to provide their Medicare number to anyone over the phone, ever, ever, ever. And to keep record of all medical events. Review Medicare summary notices, explanation of benefits and bills for accuracy before paying. And to take action if you suspect errors, fraud, and abuse. And again, I want to remind you that this is not just limited to Medicare beneficiaries. This can happen to any one of us. Our medical identity can be taken from us, and that's problematic. It's becoming even more problematic with the advent of electronic medical records. If something gets written up in my medical record because my medical identity has been compromised, and I am in a position where I need medical attention and someone has access to my medical record with all the compromised information on it, I may get adverse treatment. And so that's that's problematic. So we all need to be very, very vigilant of our identity, protecting our identity, So a word of caution, encourage beneficiaries and be very aware not to pay our bills until we have compared them against the Senior Medicare Patrol, against the personal health care journals and the Medicare summary notices and or explanation of benefits and any other insurance statements people have. Encourage people to really trust their gut. That gut test, there's a lot of credibility to that. If something does not feel right or sound right, it probably isn't. And so trusting our gut is a good thing. Contact the Senior Medicare Patrol program, the Massachusetts one if you're in Massachusetts, or your local if you're out of state. By calling, in Massachusetts is the number you call. I will be giving you the number for the resource center as well. So just to remember that it's everyone's responsibility and that we each hold the key to preventing healthcare errors, fraud, and abuse by becoming fully engaged consumers and encouraging our friends and our loved ones to ask questions. In fact, in our personal health care journals, we have 5 very important questions that we have added to the journals, and we've translated them. We also have these journals available in multiple languages. So if you are working with a particular language group and you would like journal, and I'll tell you who they are. They are Chinese, Portuguese, Vietnamese, Korean, Russian, English, of course, and Spanish. So we have these journals in all of these languages. And so back to the questions, to ask lots of questions. And we've partnered with Consumer Reports and the Choosing Wisely campaign questions. And there are 5 essential questions which are integrated in our journal to ask your doctor before any test, treatment, or procedure. 1, do I really need this test or procedure? What are the risks or side effects if I have this done? Are there simpler and safer options that I could opt for? What happens if I don't do anything? And how much does it cost? And will my insurance pay for it? Now, and to just ask these questions of your physician is, already informing them that you are engaged. These are important questions to be asking. If I'm 80 years old, do I want that colonoscopy? Maybe not. If I were to go to the doctors and they were to tell me that, my kidney was, a low-functioning kidney, and that I could have surgery, but, maybe I don't want to have surgery. Maybe I want, I'm going to wait it out, wait and see what happens to the kidney. So these are things that people really need to be asking themselves, these questions, and then asking their physician the questions and having a dialogue, having some kind of rapport. And having that kind of a dialogue and rapport leads to a good partnership and better health care. So I wanted to show you cost and consequences. I don't know if I click on here, we'll be able to see this or not, but I'm going to try.
Unfortunately, I was going to say
no?
that won't work. That won't work really well. So what I can do is it may play, but it won't play very well. So what I will do is I will be happy to share that link with our participants along with the document with the phone numbers later this afternoon. But that would be wonderful.
Great.
Thanks, Lucilia.
Great. Okay. So I'm going to just tell you that Antonio's story is a very personal story for me. It's the story of my father, and it really illustrates the cost and consequences of healthcare errors. And had my father undergone his surgery. I won't give you too much of it because I want to pique your curiosity so you can see it's a 4-minute video. It's not a long video. But he cost the Medicare system hundreds of thousands of dollars, which Medicare today would not have paid for. because my father was a victim of a hospital-acquired infection and then a serious reportable event. And so he was victimized by our healthcare system twice. And I don't want any of you to ever have to go through anything like that, although I think there may be some of you on the call who know somebody who has, if not yourself or a loved one. So we need to be vigilant. We need to be watchful. And I just want to leave you with that and take any questions that you might have.
Fantastic. Thank you so much, Lucilia.
And so here's our contact really quick. All right, S&P Resource Center down the bottom, and you will have these slides, so you'll be able to have this information. And then I just want to thank you in many languages. Thank you very much, everybody, and have a blessed day.
Lucilia, thank you so much for taking the time to share your expertise with the NeedyMeds users. If you can, go ahead and switch the screen back to me, and on my PowerPoint presentation, I'll go ahead and put up some contact information for Senior Medicare Patrol as well as NeedyMeds. And as our audience can see, why we keep asking Lucilia to come back, because she takes what can be a really complicated and overwhelming topic and breaks it down into digestible, understandable points and makes it really clear how important advocating for ourselves is and advocating from our family members is. So thank you for that. It actually doesn't look like we have any. Go ahead, Lucilia.
Was I successful at doing that, at switching screens?
Yes, and everybody should be able
to
see my screen now, which is just NeedyMeds cost savings resources. And I will remind everybody, I don't see that any questions have come in, but if anybody listening is like me and all the questions come flooding in after the webinar is over, again, we will provide you with the contact information at the end of the webinar. And of course, I'll follow up with everybody to provide you with all of our contact information, as well as the phone number that Lucilia will provide us with, that the document that provides all of the important phone numbers, as well as the video hyperlink to Antonio's story, which sounds very compelling. I also want to mention, don't forget to learn more about NeedyMeds by visiting our website or giving us a call at our toll-free helpline, which is 1-800-503-6897. If you are having trouble affording some of your healthcare expenses. Certainly, I do want to point out that we at NeedyMeds don't offer direct financial assistance. Rather, we connect programs that do. And certainly, sometimes a program you may not be eligible for, but we will work our hardest to try and find you a cost savings option for all of your healthcare needs, including but not limited to medications. I also want to take just a moment to point out that we do have two other special topic webinars coming later in December, and you can find out more information about these webinars and register for them on the calendar of events on the NeedyMeds homepage on the bottom right-hand side. As promised, there is contact information for SMP as well as Medicare, as well at the bottom contact information for NeedyMeds if you have any questions about help saving on or affording your current medication or healthcare needs. As I said, I'm happy to follow up with everybody later this afternoon with an email with that document of phone numbers, the video, and just in case anybody had a hard time downloading today's PowerPoint presentations, which are in the handout section of your GoToWebinar control panel, I will include those as well in the follow-up email. With that, Lucilia, thank you so much again for taking time out of your busy schedule to share your expertise with the NeedyMeds users. And to our participants today, thanks so much for taking time out of your schedule to join us. And we do wish everybody happy and healthy holidays. Lucilia, I'll follow up with you as well later this afternoon. Thank you, everyone. Happy holidays.
Thank you very much. Happy holidays to all. Bye.